Welcome, everyone. Thank you for joining us for today's webinar hosted by the NIH-funded MD2K Center based at the University of Memphis. Today's webinar is a deep dive into the intersection of mHealth and Squid Games and Game of Thrones and Breaking Bad. Probably one of the most intriguing webinar titles that I've encountered in a long time. And it was not conceived in Hollywood, but in very staid Switzerland by our speaker, Tobias Kowatsch, from the Center for Digital Health Interventions at ETH and St. Gallen. Toby is a rising academic star who designs digital health interventions at the intersection of information systems research, computer science, and behavioral medicine. Beyond injecting a European perspective on mHealth, I'm also very anxious to learn more about how it ties mHealth into popular culture. Just a little housekeeping before we get started. A recorded version of this webinar will be available on the MD2K's mHealth Hub. Please make sure you are on mute. If you have any questions during the presentation, please raise the hand symbol in your Zoom window and we will unmute you. We will also have time for questions or discussion at the end. Having said that, over to you, Toby.
Thank you very much for this introduction and a warm welcome and hello from Singapore. It's a pleasure to be part of this webinar, and yeah, as already introduced, I think I simply start sharing my screen and then start the presentation. Before I'm looking then very much forward to your comments and questions to what we are doing. Yeah, you mentioned it already. The key question of this webinar is what can we learn from these successful TV shows, Squid Game, Game of Thrones, or Breaking Bad, to lower the socioeconomic inequalities in health. And I would like to start with the question of what is the fundamental problem we try to address with the other question. And it is, of course, the health and the economic burden of non-communicable diseases. And I include here also common mental disorders. Examples are cancer, diabetes, asthma, COPD, Alzheimer's disease, major mental illness. And from a health burden point of view, we know that NCDs are the leading cause of death. And when we look at the trend, this is unfortunately affecting more and more people. And also from a health economic point of view, we know that, for example, in the developed countries, approximately 80% of all the healthcare expenditures are directly linked to NCDs. But I think this is very clear so far. I would like to go to another problem, which is the following, a very much specific problem from the perspective of socioeconomic inequalities. And that is, we know that individuals with a lower socioeconomic status are substantially more affected by these non-communicable diseases. And why is that so? And what can we do? Well, I would like to bring in here only 3 building blocks. I mean, there's many others, but 3 that are very important is, of course, the first one here, which is all about infrastructure. So the idea is here, of course, to increase access to healthcare in general. And when we are able to do so, then we should deliver health literacy through this channel. So knowledge would be the second building block. And as you all know, knowledge is not good enough. We also then need to support people in their everyday lives, in their health promoting behavior. So these 3 building blocks will be discussed later as well. So, but now let's come back to the title of this presentation. Why would we now look into like these TV shows, Squid Game, Game of Thrones, or Breaking Bad? Well, first of all, as you see it here to some degree in terms of the awards they won and the ratings they have, they were among the most successful TV shows ever produced. They reach millions of individuals out there. And what's very important, those individuals are reached in their comfort zones. So, you know, being around, being in their homes, or watching TV or watching these kind of shows on the smartphone. The second very important aspect is they are, and this is very specific to non-communicable diseases, they are episodic and usually tell their stories over the course of several months or even years. So it's not like, you know, you have a health issue and then we fix it. As with specific acute diseases, now when it comes to major mental illness or when it comes to non-communicable diseases, then many individuals are affected until the end of their lives. So this analogy, although I'm also a big movie fan, the analogy of TV shows is the better analogy. And finally, we also know this from empirical data, although it is very hard to have empirical data about individuals with low socioeconomic status. We know that with TV shows, but also, you know, channels like YouTube or Twitch, we can reach individuals with a lower socioeconomic status. And thus, looking at the characteristics of these kind of TV shows may make sense when we think about maybe improving the design of also digital health interventions in general, with a primary objective to reach and engage substantially more individuals with a lower socioeconomic status. And I would like to bring in now 5 characteristics of these TV shows. And the first one is that TV shows are scalable. And this is, of course, when you have a technical background, very clear what is meant by it. The idea is, of course, that, you know, you produce a TV show once and then you don't have any significant additional effort for an additional viewer of the TV show. And why or how scalable are interventions offered by top-funded digital health companies out there? And what we did here is we used financial databases such as PitchBook or Crunchbase, and we looked into these digital health companies, that is companies that use technology to deliver their interventions. And we focused on 2 areas. One is diabetes here on the left-hand side, and on the right-hand side on digital health companies that offer interventions in the mental health space. And you see here the top funded companies, you see the total funding in million US dollars. And what we then did, we kind of dissected their services. We tried to understand how they are delivered. And when you look at this aspect in terms of scalability, then we see that most of the interventions that are delivered are predominantly delivered by humans. So that means technology is very often used as a communication channel. And thus, scalability is limited. Why is this relevant? Coming back to the first building block is, of course, access to healthcare. That might be then a huge issue. Is there any evidence, I would ask now, that health interventions can be scalable and effective, especially for individuals with a lower socioeconomic status? And I think, you know, that last part, especially for individuals with a lower socioeconomic status, this is very hard. And I bring here only one project with a limited number of patients, a project that we started like 8 years ago. We have a patient population here that's children and adolescents with obesity. And we developed a mobile health application, a holistic mobile health application that focuses very much on behavioral support in the everyday life, with a focus on physical activity, diet behavior, and also stress management aspects. And it was also a blended treatment. So we had interactions, or those young patients had interactions with healthcare professionals, but of course also with the health app. And what we did is we measured the number of interactions that have been conducted over the course of these of the 6-month intervention. And you see here the percentage, the distribution of how many interactions have been done with the app versus how many interactions have been done with the healthcare professionals that were involved in it. So in total, we had around about 18,000 interactions. And it might seem, that this is kind of scalable. And the question is, of course, well, is it still effective? And we need to be very careful here because the number of patients is quite limited. However, we were able to publish that study, and at least we're able to show that fat mass in these individuals decreased significantly. But again, we need to be very careful, as it is in general very, very hard to reach and engage those individuals for these interventions with, specifically with lower socioeconomic status. But that's at least the aspect in terms of scalability. Let's come to the next one. So in here, the next characteristic is that we say TV shows are low burden. What does it mean? Well, you sit down, you turn off your TV, and then you just enjoy watching your TV show. So why would that be relevant for health interventions? So the question is, how burdensome are the most popular health apps out there? And similar to the companies, we looked again into the most popular health applications out there in the area of mental health. So you have these apps such as Headspace or Calm, and we did the same also for diabetes applications. But I show you here the result for the mental health applications. So how burdensome are they? And of course, the question is linked to the number of interactions and sort of interaction that is done, that is required to measure, for example, specific vulnerable states. And we had two major categories here. One is, of course, the self-reported data collection in relation to these constructs you see here on the left-hand side versus the use of sensor data to do the very same thing. So, for example, to use the prosodic features of the voice, that is specific characteristics of the voice that can be potentially used to detect the emotional state of an individual. We would call this then a digital biomarker. And as you see, well, there's a lot of zeros here, and we can conclude here, as written on the right-hand side, today there's still a huge untapped potential of using digital biomarkers in our center, and others are working very hard on these digital biomarkers to reduce the burden of interventions, because people don't have time and people are not likely and are not so much interested in having many interactions, because, I mean, at least at our center, we have this goal to build so-called just-in-time adaptive interventions, where then the vulnerable state is measured as unobtrusively and passive as possible, to then come up with the most relevant micro intervention that helps then these individuals, right? We don't want to spam patients or healthy individuals with these kind of burdensome interactions. We see, by the way, similar patterns for the field of diabetes. And of course, we as researchers should be encouraged to do better in the design of future health interventions. One example we did, right, so we tried to do this better. One example is this here. Low burden health monitoring while we are sleeping. And what we did here is we used the microphone of the smartphone to detect the number of nocturnal coughs in asthma patients, in brackets, that was before COVID. Afterwards, many other research groups did, of course, also a lot of scalable cough detection with the smartphone. But the focus here was really to do this in asthma patients. And we did so for 1 month of approximately 90 asthma patients. So we had longitudinal data, and then the research question was, do we see in the nocturnal cough rate, can we see a signal so that we are able to predict asthma control or an asthma attack? And the results of the study were then so promising that we saw a signal approximately 3 to 4 days before a bad asthma control was then measured through these kind of validated self-report questionnaires, which were delivered through this conversational agent, as you saw it here, so that we could see 3 to 4 days before that there might be an issue in terms of vulnerability, that a startup was even incorporated, like Rasmonics, and who are now developing a product out of this kind of study to then help many individuals out there suffering from respiratory conditions. So that is just one example in terms of how low burden health monitoring can happen. You're just using a smartphone, and the smartphone listens to your nocturnal cough, and then comes up with an early warning to prevent hospitalization, which is then, of course, both burdensome, like in terms of a health burden for the patient, but then also in terms of health economic costs, very costly. So the idea is to here develop an early warning system to prevent these kind of life-threatening events. Let's come to the next aspect out of the 5, which is probably very obvious when we look at these kind of TV shows, because usually TV shows are entertaining, right? Engaging, so that you then hopefully watch the next episode. So, and the question then here is, how does the engagement look like of these kind of TV shows versus popular digital health applications? And here again, we looked into mental health apps and into popular mental health apps. And what we see here on the left-hand side is the average viewers in millions here of Game of Thrones over those 8 episodes and 8 seasons and 73 episodes. And you see they did quite well. This looks quite promising, and all of us digital health researchers would love to see these kind of numbers for their interventions. But then when you look into the chart retention curves of popular mental health apps here, for example, you have this kind of classic pattern of a long tail curve. So after 10 days, only less than 10% of those who downloaded the app open the app up again. So, and the question is here, of course, what can we learn from the left-hand side so that the right-hand side, the steepness of the curve is not so steep, so that we have more users. And well, coming back to this idea of entertainment, we could maybe combine entertaining content, pop culture content, with evidence-based content that we know works from the behavioral medicine field, from the medical sciences. And how would that look like? Well, we use this kind of evidence-based health content, for example, a slow-paced breathing training, which has several positive effects on the physical and also mental health side. And then we expect to have a positive health outcome here, in this case, a reduction of acute stress. But what we now do is that we add on top of this entertaining content, like exciting content, pop culture content that is really linked and culturally relevant to the specific individuals we try to reach. And here the outcomes are then entertaining outcomes, hopefully enjoyment, hopefully adherence to the intervention itself. And with this enjoyment and with this adherence, we then also foster the positive health outcomes. And coming back to why we are looking at TV shows and not movies, we have, of course, episodes, and package this in kind of episodes. And the idea is, if you have identified then a vulnerable state in an individual, and this brings back the idea of just-in-time adaptive intervention, then you would then send out the most appropriate content that is then relevant to this specific person in that moment. I would like to show you also an example from our lab. So we do these kind of slow-paced breathing trainings, also technology supported, and we have implemented a mobile application. It's called Stressless, and here you see the classic of slow-paced breathing trainings, this kind of circle that is extending and contracting. Inhale, pause, exhale. There are specific breathing patterns. You can substantially reduce, for example, the heart rate, or increase the high frequency portion of the heart rate variability. So this is one version you can do it. But then, of course, let's package it in a way that is more storytelling driven. We have then developed another version, Tragic Kingdom. We called it Tragic Kingdom. And here the idea is that we use, again, the microphone of the smartphone to detect the noise we make when we inhale through the nose and exhale through the mouth. And when we exhale through the mouth, the idea is that we then push the sailing boat forward as you see it here. And you may ask, yeah, well, you know, this is maybe too entertaining and too joyful that you can't relax. We showed already in the lab from a physiological data point of view that both breathing exercises that you see here on the left-hand side and also the right-hand side, both were equally efficient in reducing the heart rate. Also when we ask the individuals about their perceptions in terms of enjoyment, we see the right one here, the Tragic Kingdom version was perceived significantly higher in terms of perceived enjoyment compared to the other one. And also when we would ask individuals, perceived effectiveness of the slow-paced breathing training was equal and high in both of these kind of versions. So we could conclude that at least for Tragic Kingdom, health effects are side effects. Maybe a take-home message when we think about developing health interventions in the future, especially for those with a lower socioeconomic status. Which is then the question, right? Is there any evidence that health interventions can be engaging over a significant amount of time, and especially for those individuals with a lower socioeconomic status? And I would like to come back to this example I started, that study we did with the children and adolescents with obesity. Again, a small sample size here. However, in terms of low socioeconomic status, we know from this patient population that they have an immigration background, that usually the parents are divorced, that they do have a lower socioeconomic status and are, of course, under a lot of pressure in school, etc. So a really, really hard to reach and engage patient population. Nevertheless, I was so happy to see then this kind of chart, which indicates the average daily goal achievement rate of those 18 young patients. And that means every day over the course of those 23 weeks, there was a challenge. Every day, so even on Saturdays, even on Sundays, they had to do, for example, reach a specific step goal, or on specific days, they had to take a photo of everything they eat and drink, so that this could be then, you know, discussed about in a on-site consultation session. And we did this kind of intervention with the storytelling part of it. And we did the very same intervention with the very same patient population without storytelling. So we did not connect these kind of challenges to each other and see what happened. And this was, of course, the study before. Like that was the first try. And after a couple of days, after 2-3 days of, you know, euphoria that, oh, there's an app as part of this intervention, they did not use it at all. And this kind of application was rather around, you know, like a Fitbit dashboard, so that you see how many steps you did, etc. Whereas then the new version with the storytelling connected the dots. We tried to bring in this sailing boat, the slow-paced breathing training, as you have seen on the other slide, this kind of story, so that you have to, you know, from time to time, take the boat to travel to the next isle. On the isle, you had to search for food, so you had to reach a specific step goal. And when you found food in that kind of story, then you had to take a photo of everything you eat and drink on that specific day. So that was the storytelling we implemented, and you see here the difference. Again, we need to be very conservative with these kind of data. We did not systematically evaluate it. We did not have a randomized controlled trial with and without storytelling. However, a similar patient population, and in both cases, it was a mobile health intervention to support those obese children. Okay, we are almost done. The fourth characteristic, maybe because of the slow-paced breathing training, let's take a deep breath before we move on. I take a drink quickly something. Okay, the fourth characteristic now is TV shows offer relatable characters. So what does that mean for our Squid Game, Game of Thrones, and Breaking Bad? Well, for Squid Game, our main character struggles financially. Jon Snow in Game of Thrones, is asking himself in all of these kind of episodes and seasons, the most important question in our lives. So, what is the goal? Where do I belong to? What is the social system? And within that social system, where's my place? I think a very fundamental question. And then Walter White in Breaking Bad, himself diagnosed with lung cancer. And his goal is, just to secure his family. And these kind of characteristics are to some degree very common and relatable. And this is what I mean with relatable characters may matter very much. And well, the question now is, of course, again, why having relatable characters in health interventions? Why would that make sense and why is that important? Well, it is well known that this concept of working alliance between a patient and doctor, and this is working alliance is a relationship quality that is, the degree how much you trust your doctor as a patient, and it is also a shared understanding about the treatment goals and the specific treatment tasks that have to be done to reach then these treatment goals. And we know that this working alliance is robustly linked to treatment success. And these are 3 meta-analyses that have been done. And then coming back to the first characteristic, scalability, right? I mean, patient and doctor is one thing. Can we also build working alliance with maybe or in a very scalable way? So can we frame computers as social actors and build up a working alliance with patients? And well, yes, of course. I would definitely recommend you look at all the work that Timothy Bickmore at Northeastern University did the last 20 years. He has shown a couple of times, and we also did in a couple of our studies where we used conversational agents for healthcare purposes, that you can build up a relationship with computers when you add some cues that make them more human. And this is, of course, very important. But again, the question, is there any evidence that individuals with a lower socioeconomic status can build up a working alliance with conversational agents? And here I come again back, and you see from slide to slide, you see always a little bit more about that intervention we did for the children and adolescents with obesity. So we had these kind of conversational agents. I'm so sorry, they are so stereotypical, but when we designed that a couple of years ago, it was then also the marketing department of the children's hospital that helped us, and we were not the best designers, and we were just happy what they gave us. So we had 2 conversational agents, Anna and Lucas, and the application itself was very, very easy to use. It was really like WhatsApp, etc., even easier. You don't need to write your answer as a text, but just use predefined answer options as you see here. So we had these conversational agents, and now coming back to the question here, we measured working alliance then between those conversational agents and those young patients. And, here's the scale. 1 is a low working alliance, and 7 is a very high working alliance outcome. And what we also did, because it was a blended treatment, we also wanted to know the working alliance between the patients and then the healthcare professionals, the team that was also there. And I think with 5, those conversational agents scored quite good. And the question is then, with the real human beings, yes, they did better. And I think they did substantially better, because you have to know it was a blended treatment, but of course the health professionals were not there every day for those young patients. They met them only 6 times during those 6 months, whereas Lucas and Anna, as you remember, every day there was a daily challenge. So they had every day kind of the intention was to have an interaction with Lucas and Anna. So I think still an interesting result. And as we know from these meta-analysis, they might have a positive impact on the outcomes. And as I have already shown on this other slide, we could show that some of the physiological measures we did with these patients, that they improved. All right. Now, the last characteristic. And here, this is more future related topic. TV shows characters talk. I mean, that's very obvious. And then the question, of course, why would it be important to deliver health interventions through voice? And of course, there's some obvious answers to it. First one being, we are used to it. I mean, we human beings, we talk to each other. That's simply natural interaction. And then it has also the benefit as it is hands-free. So for example, physical exercises, or when you do a mindfulness exercise and you close your eyes, then a voice-based intervention might be helpful as well. And then here, the third point, of course, when you have someone with disabilities, then voice might be the option to offer. And of course, there's a lot of examples. For example, a lot of skills that have been developed by the American Heart Association, American Stroke Association, of course, by other companies, so that you can then ask Alexa, my partner has a stroke, what can I do? Currently, you have, of course, a big disclaimer when you install these kind of skills, that you are, of course, told that you should not use these kind of skills in a serious health event. So it's more for health literacy purposes. However, I foresee a future, of course, where then and when this happens, and maybe it is measured with a microphone in addition to, in addition to an interaction, so that then Alexa may do or may take over the emergency call, and then also help the romantic partner of the person who is the target person here in suffering, to help with very specific instructions to manage that life-threatening event. Is there anything else why voice would be relevant? Well, we also know from studies that spoken animation is among the best ways to communicate complex health information to people with low health literacy. And thus, we also produced a couple of health literacy video clips here, in this case for children with asthma, and we're also able to show in a first feasibility study and based on a pre-post test that we could substantially, with a big effect size, substantially increase the health literacy in those young patients, 10 to 14-year-old patients with asthma. Yeah, and this is now the last project. This is the reason why I'm here in Singapore. This intervention tries to bring all the things that we have learned now kind of together, including the voice-based interactions. And the idea is here to address the problem we see in our studies from the past, that very often, and unfortunately, only those participate in studies, those with a higher socioeconomic status, those that are more healthy, those that are more motivated and engaged in these kind of studies and health behaviors. And with Level Up, we really wanted to address this selection bias, and thus, of course, that is not a consumer or participant facing like claim this healthy longevity for everyone. This is more for the research community. But what you see and how we promote this Level Up intervention is it's more like a TV show. So we produced a TV show with 4 episodes, and maybe this is the moment where I would like to quickly share the screen of the smartphone and then to guide you through the application, so that it's more transparent. So just give me a second to do so. Okay. So Level Up is here on the bottom right. So I just start the app. And yeah, coming back to the TV show character, the overall idea of Level Up is that you level up. And when you level up by doing specific health-related tasks, we would then unlock the next episode. So the first episode of Level Up Season 1 is available. Maybe I can show you the first 20 seconds of it so that you get an idea of this kind of soap opera. Let's see.
Oh no, it's already this late? No wonder Alex is calling me. Hello?
Kai, finally! Please tell me you're on the way. I've been waiting awkwardly at the restaurant for almost an hour.
So I think you got the idea. So our main characters in Level Up, they are running into various work-life balance issues, right? Working too late, having not enough sleep, having not the best diet, etc. And when you level up in the application itself, then we would unlock then the next episode, like something's got to change, taking steps and then reaching new levels. And the idea is that these characters in this TV show, that they are struggling hard in their everyday life with many, many different things, but they also learn to better cope with this situation. And this is maybe now a spoiler for you. I mean, we have, of course, a happy end, but then they talk to each other and say, hey guys, we were struggling so hard, but we also learned from each other how to cope with the situation. Why not sharing our experience with others? And this is the reason why the first thing after downloading the app is you select one of these characters as your digital coaches, and we frame them really not as, you know, I'm the medical doctor, I know everything better with this finger pointing, you have to do this and that, etc. No, they are framed as peers, someone coming back to the relatable characters I mentioned before. We frame them as relatable characters, could be you, could be me, that then take you and guide you through actually 3 pillars: eat well, stress less, and move more. And you get then here, let me quickly go back to the sheet because that's kind of the main idea of it. You get specific recommendations and tasks you can do. We have, of course, also a conversational agent here. So I selected this character and I don't know whether the team is working on it. So whether this is interacting. Yeah, so this is, yep, that's correct. All right. So you have these kind of interactions then with the conversational agents. And here, of course, we would like to bring in this working alliance aspect so that you can build up a working alliance with the conversational agent, which is a relatable character here. So here you learn about these 3 life areas here: eat well, stress less, and move more, depending on a quiz you do at the beginning. So we want to know the vulnerable state. And then we would suggest you specific life hacks, coaching sessions with the digital coach, and tools. We have also incorporated that slow-paced breathing training you saw, where you can then push the sailing boat forward to reduce acute stress, to fall better asleep, to reduce blood pressure, and many other things, etc. So this is the current prototype. We are doing or in the stage of final bug fixing, and then do the first feasibility study. This will start in July here in Singapore. And just in case, if you click on the shield, you get an idea. For example, you have to do 6 level up basic tasks, 6 coaching sessions. You have to implement 1 life hack, or you have to do a 1 journal entry, or do this slow paced breathing training, which we call here breathe. For level 2, for level 3, you have to do these number of actions in the app. And yeah, we're looking very much forward. We never did this kind of combination of TV show episodes unlocking when you do specific things, but what we also never did is that we promote it really like as a TV show that is exclusively available on the smartphone. and where the idea is that you join the characters, those 4 characters, and then strengthen your body and mind. So it is a preventive care, a holistic preventive care intervention with the overall idea of healthy longevity, so that you have a healthy lifespan. Well, with this, I would like to conclude and maybe just wrap up by coming back to those 5 aspects. So the first one, TV shows are scalable. So let's design health interventions that heavily use widely adopted consumer technology, so that we can, provide a good infrastructure and access to health interventions. TV shows are low burden, so let's design health interventions that leverage digital biomarkers for just-in-time support. TV shows are entertaining, so let's design health interventions that combine both entertaining and evidence-based medical knowledge and content. TV shows offer these relatable characters, so let's design health interventions that are delivered by relatable conversational agents. And finally, TV shows characters talk, so let's design health interventions that offer natural voice interactions. And with this, I would like to thank you very much for your time, and I'm more than happy to take your comments and questions.
Yes, this very fascinating. You really got me thinking. I never thought about it, but like the Game of Thrones transcends not just SES, but also countries and cultures. And it keeps increasing. And what is so striking, in our case, we always, with behavioral interventions, and after a few weeks, we see that deep dive. And it doesn't scale across cultures, and certainly not across countries. Do you, I'm just wondering, because it's all about engaging the patients. And I got the sense you're working with different engagement strategies. Just want to get this conversation going. Are you engaging here in Hollywood? We have script writers, we have showrunners, they're highly paid, they're highly talented, they know how to develop a storyline that addresses so many different, I would say, phenotypes. Do you have anything like that in your development of these apps?
Yeah, absolutely. You're so right. We do. My first studies were media and computer science, and we had to write also scripts back then, etc. We did video production, we did audio production, etc. And we engaged, for example, also for the project for children with asthma. When we had these health literacy video clips for children with asthma, we also engaged a script writer who wrote the storybook of it. And for the Level Up intervention I showed you here in Singapore, we're working together with Lionfish Studios, a studio here in Singapore that knows about the culture, that knows how to make it in a way so that it finds attraction. The interesting thing, for example, with Squid Game is, and that was written by an author from South Korea, that was kind of a worldwide success, which is kind of interesting. Of course, I see some huge challenges in terms of diet. Like physical activity, well, I mean, depending on the climate, you might suggest different activities, but diet is definitely something which is not so straightforward also to measure and then coach. But yeah, there is of course always challenges. But yeah, script writers, very important. And of course, we don't engage those that ask for millions. We don't have that budget. So that is also a first exercise for us. Like that's the first time we do this kind of TV show. But we hope to motivate others and let's see what the result of the feasibility study is.
Yeah, the highly paid ones are all in Hollywood. And that's why the shows, not all of them are successful like Game of Thrones. Things like behavioral economics, do you use micro incentives? How do you keep them engaged? We have very preeminent stress researchers, measurement and obesity. I'm curious, but how do you keep them engaged? Do you use micro incentives?
Because stress less is one of our pillars, and there is so many other health interventions in Singapore that work with vouchers, coins, points, etc. We wanted to do it differently, so we don't have any of these. We don't have any monetary incentives, especially because of that techno stress, attention economy aspect of it. When we would work, for example, with these vouchers, then we would urge people and even stress them, right, to use them. And we did not do so. Our lessons learned from the studies we did in Switzerland is that when we are able to build this kind of relationship with the conversational agents, and you saw the average goal achievement over 6 months in those young children with obesity was close to 60%. I mean, if we can show this here, it would be beautiful. And we did not have any monetary incentives in that study as well. So we hope that we are able to have these beautiful, relatable characters and build up this working alliance with them. And of course, the urge to build up that shield, there's of course some techniques to it. And of course, also the cliffhanger at the end of the episodes that they want to know how the episodes and the whole TV show ends at the end. Let's see how good this works.
So speaking about stress, so we have one of our leading stress measurement researchers, Santosh Kumar. Santosh, you've raised your hand. You want to pose your question?
So thank you, Vivek. I think Joy is ahead of me. So
okay, Joy, sorry.
I'll go after Joy.
All right, Joy, go ahead.
Thanks, Santosh. Really interesting talk. This actually is fascinating because we've been working on kind of narrative-based methods to try to incentivize health behavior change as well. And one of the questions we've been asking ourselves, and this aligns a little bit with what Vivek just talked about, was the personalization of the interventions. And I kind of ties into the relatable characters part. I'm curious if you've thought about or have information about people and their responses. Are there people who respond better to the story-based versus other approaches? Like some people are very into the quantitative. They want to see, just being able to hit that goal of 10,000 steps. I don't know if you've been able to dive into that aspect at all with some of your previous studies, or if you're looking at that in your current study.
Yeah, we don't look into that specific detail in this study right now, although, I mean, we're working now on the optimization trial. We are following here Linda Collins' MOST framework. So this is, just our first prototype. We do the feasibility study, get general engagement rates. We will see, because we have many, I did not show all the views of the application, but the idea is, of course, to better understand which parts of the intervention of the mobile application are used more frequently. We also engage very early in interviews, before they drop out. We try to catch them, have interviews with them to better understand why they like specific aspects of the app or not. So for the optimization trial, we foresee some other aspects we would like to do, especially kind of a blended treatment approach. We want to very dynamically add then a human support person, either to boost engagement and or really to help with specific with the specific pillar, like the physical activity diet and or the stress management pillar. This is what we try to then systematically evaluate before we then do the big RCT in 2024. But in another study we have completed in the German-speaking countries, we systematically evaluated that slow-paced breathing training I showed you. So we packaged it in this very, I would say maybe conservative, very careful way, saying, this is a stressless application, slow-paced breathing training. And then we had the Tragic Kingdom version of it, both versions were communicated actually as a slow-paced breathing training, we produced video clips that showed the conversational agents and also that the breathing aspect of it. And we gave it to influencers on Twitch. And then we assessed how many downloads divided by the number of average viewers they had when they promoted these different aspects. And we saw, at least for the Twitch users, and this is preliminary data, but what I see now is round about a reach rate of 36% with the Tragic Kingdom packaging, where the storytelling was very much prominent, versus it was 7% for the stressless version of it. And of course, the influencers did not know from each other. And we also used at least 2 influencers. So when one is really, really good in promoting it, so that we then have the average scores, etc. So now we see the 7% versus 36%. So at least for Twitch viewers, again, we assume that here we have more people with a lower SCS in general. Yeah, I think I can't give you more details in terms of personalization. The only thing that we have at the beginning is when you select one of those 4 characters, they are kind of prototypes. You see some characteristics of them. 2 are older. There's also a mother that has children, and then you have more two younger characters, etc. And you then also select one of these characters based on these characteristics. And they have also mini stories, and their mini stories are kind of personalized to, you know, which kind of these digital coaches you select. Yeah.
Thank you. It's really interesting.
Yes, so Toby, I would like to convey my appreciation for you agreeing to give this webinar, do this while you are traveling, and do this at a time that is convenient for people in the US. It is very, very kind of you.
Yeah, well, was not my plan. I am supposed to be in Switzerland, but I had this opportunity to show our prototype to the Deputy Prime Minister here. So I extended, and I did not want to cancel it. So yeah.
So you, I mean, you went really not just extra mile, extra a few thousand miles to make it work. So thank you. So I found your analysis of TV programs and very, very interesting, especially on its impact on the design of interventions, which is something that MDOT is at the front and center of MDOT's work. I also enjoyed you making a case for greater use of digital biomarkers, which is again something that the MDOT Center would very much like to see happen more and more. So one curiosity, I guess, more than a question, is another very popular, highly scalable medium these days is social media. Any plans to do a similar analysis and lessons learned out of these popular social media platforms, and what they what can be learned for digital intervention design from there?
Yeah, I think this links nicely back to the study we did now in the German-speaking countries. As part of this feasibility study, one goal is, of course, to better understand engagement and which kind of components of the app are used. But another component to it is that we try different channels, of course, also social media channels. We have created a couple of, or 20 or 30 different QR codes, and depending on the channel, we use different codes so that we also see later on through which channel, which kind of demographics we are able to reach. One very important component that I didn't mention, because it's called MDOT, or also our center, like, it's called Digital Health Interventions, but again, coming back to the stress-less pillar and techno-stress and smartphone addiction and the attention economy, we have also developed like a booklet completely offline. And we will also distribute this in vulnerable areas within Singapore. I have learned from other studies, if you would like to get a regular blood pressure measurement, also in vulnerable individuals, you maybe do it with a hairdresser, because people go on a regular basis, for example, to these kind of locations. So we try to hijack this idea also here and to have the essence of Level Up also in an offline version. Here you get the instructions on how to do slow-paced breathing trainings. I did not talk so much about the life hacks. Life hacks are these very short and sweet, like habits or nudges we give people as an inspiration. You can cut them out, you can put them on the fridge, etc. So this is part of this offline Level Up experience. We are thinking about cardboard games for families, so that we really go more the route of social health. I mean, there's a lot of mental health and physical health, but social health can be also promoted much more in the future. So there might be even a Level Up cardboard game where then, or even a children's book, a Level Up children's book, where, you know, the young children love the stories. Again, the health effects are the side effects that you also learn, but we then would leverage the high neuroplasticity of those young individuals to frame it in a way that they remember these stories even when they are then older, etc., and hopefully apply what they have learned in that as well. But the beautiful side effect is that they force at least one family member, like the mother or the father, to read these stories. And then you can't resist, you have to digest it as well. So, and then you have even a scalable intervention component within your family, without having the huge costs of, you know, then the healthcare professional taking care every day in the everyday life, which is of course not feasible. Yeah.
Sounds wonderful. Thank you, Toby.
You're welcome. Thank you.
Thank you. I would have taken more questions, except I know it's 12 midnight in Singapore. You've been very generous joining us and sharing your exciting work. Thank you again to the audience. I just want to remind that this recorded version is will be posted on mHealth Hub, and for asynchronous access to others. And I thank you all for joining, and we look forward to seeing you at the next webinar. Thank you.
Thank you.